Hello everyone, this is Group 22 and today we will be discussing a case of a 30-year-old male who is marathon runner and presenting with a sudden episode of syncope during the final mile of a race. He experienced a sudden collapse with running with brief LOC that recovered rapidly. He had no preceding chest pain or dyspnea, but he had a headache before syncope. He feels lightheaded during intense training despite hydration. He has no history of syncope, heart disease, or any other conditions.
Family history. Family history reveals that his father was diagnosed with hypertrophic cardiomyopathy at the age 40. However, there is no family history of sudden cardiac death or arrhythmias. Socially, our patient is a non-smoker and consumes alcohol occasionally. He don't use any recreational drugs and he works as software engineer and regular marathon runner and trains 6 days per week.
On physical examination, the patient is a well-nourished, athletic male who's alert and oriented. His vitals are heart rate 58 beats per minute, respiratory rate 14 per minute. On systemic examination, his cardiovascular exam showed regular rate and rhythm with no murmurs, rubs or gallops. His peripheral pulses are 2 plus bilaterally. His respiratory exam showed clear lungs, no rales or wheezes. His neurological exam showed no focal deficits and he had steady gait. There was no cyanosis, edema or clubbing noted. Next slide. To further evaluate his condition, initial diagnostic tests were performed. On ECG, sinus bradycardia was noted with left ventricular hypertrophy. There was no ST segment changes or T-wave abnormalities. His lab tests were normal. On chest X-ray, there was cardiomegaly noted. Orthostatic blood pressure measurement, no significant drop in BP upon standing. Differential diagnosis. Hypertrophic cardiomyopathy is likely with the family diagnosis LVH on ECG and exertional syncope, but it might be silent HCM because no murmur was seen. Athlete's heart shows LVH and bradycardia, but we will rule this out because in athlete's heart, hypertrophy regresses with stopping the training and it also lacks a family history. Arrhythmogenic syncope involves sudden collapse and LVH but is unlikely without documented arrhythmia or elevated troponin. Dehydration or heat stroke may present with exertional lightheadedness but is ruled out by normal electrolyte and orthostatic hypotension. Subarachnoid hemorrhage should be suspected with a sharp pre-syncopal headache but is less likely without neurological deficit or confusion. In SAH, pre-syncope might be a red flag but ruled out because no neurological deficit were found. Therefore, the final diagnosis in our case is hypertrophic cardiomyopathy with exertional syncope.
Justification. The key symptom here is exertional syncope, which immediately raises concern for a cardiac cause. And the most likely culprit is hypertrophic cardiomyopathy, HCM, due to left ventricular outflow tract obstruction. One of the biggest clues pointing toward HCM is the family history, since it's a well-known hereditary condition. Then, looking at the ECG and chest X-ray, we see signs of left ventricular hypertrophy, which further supports this diagnosis. Other possible causes of syncope were considered, but ruled out, making HCM the most probable explanation. Now, we will discuss the case questions. Now, comparing HCM to dehydration. While dehydration can also cause syncope, it typically presents with sinus tachycardia, postural hypotension, and has no genetic link. In contrast, our patient has exertional syncope, LVH on ECG, and a positive family history, findings that strongly favor HCM. Furthermore, this patient has normal electrolyte levels, well hydrated, and does not have orthostatic hypotension, which makes dehydration unlikely. With all of this in mind, the most reasonable conclusion is that the patient's syncope is due to HCM with LVOT obstruction rather than dehydration.
The key concern is distinguishing between neurological and cardiac causes, both potentially life-threatening.
A sudden sharp headache before syncope suggests subarachnoid hemorrhage, especially with exertion warranting urgent CT brain to rule out aneurysmal rupture. Hypertrophic cardiomyopathy is also a concern as LVOT obstruction or NSVT can cause transient cerebral hyperperfusion and headache before syncope. Since management differs, SAH must be ruled out first with imaging followed by cardiac evaluation. Next slide. Since HCM is an autosomal dominant disorder, first degree relatives have a 50% risk of inheriting the condition. This strong family history suggests a genetic cardiomyopathy rather than an acquired cause of left ventricular hypertrophy. Given the risk of sudden cardiac death, early detection is crucial even in asymptomatic individuals.
Some of the additional testing to consider are echo, cardiac MRI, Holter ECG, genetic testing for MYJ7, MYBPC3 mutations, and family screening for first degree relatives. Next slide. Normal troponin rules out MI, eliminating the need for antiplatelets or anticoagulants. ECG showing LVH and family history suggests HCM, requiring echocardiography to assess LVOT obstruction and Holter ECG for arrhythmia detection. Management focuses on beta blockers or calcium channel blockers for symptom control. Family screening is crucial to identify at-risk relatives and prevent sudden cardiac events.
If another syncopal episode occurs, ensure ABCs place supine with legs elevated and monitor BP, SpO2, ECG, and glucose. If ventricular tachycardia and ventricular fibrillation, perform defibrillation with IV amiodarone. Evaluate with echo, Holter ECG, and cardiac MRI needed if fibrosis is present. ICD is indicated for NSVT, SCD history, unexplained syncope, or LV wall thickness if it is more than 30 mm. Manage LVOT obstruction with beta blockers wherever meal. Avoiding strenuous activity. Follow-up includes ECG, Holter after 6 to 12 months, fibrosis assessment, and septal ablation if the symptoms persist. Our key clinical points include that exertional syncope is a red flag, due to which cardiac cause is suspected. Family history of higher HCM risk, therefore early screening is a must. Echo is the best test for HCM and beta blockers are first-line treatment. ICD is needed if high risk for SCD. Avoid competitive sports. Here are our group members. Thank you so much.